Dr. Seshkin. Hello, Dr. Goldstein, and all friends in the room today. Mine will be a clinical presentation. I have, as of now, consulted on 123 women with endometriosis. I know that because I counted yesterday, and I come without slides, so you'll have to bear with my voice. I listened to them, and as I listened to these young women describing their internal world, and it's a constant, the varying degrees of endometrial pain. But over time, I also became sensitized to panic. Over and over again, panic everywhere. I heard it everywhere. Likewise, conflicts about containing and managing panic saturated our conversations. Since at my age, I'm probably getting better at learning to see what's right in front of me, I began trying to model this. Suffice to say that it is rare to find a woman who is not treated for endometriosis, who is a stranger to attacks of panic. I would estimate that the base rate of panic in at least the 100 plus women I saw is at least 80%. At the same time, the experience of endometrial pain is subjective. Such pain is related to a host of factors. Of interest, it is not significantly related to the degree or the aggressivity of actual endometrial lesions. It cannot be emphasized strongly enough that reactions to endometrial pain are idiosyncratic. We must throw away the playbook when assessing and treating endometrial pain. There's a voluminous literature elsewhere, for example, in back pain, which demonstrates that most chronic pain patients screen positive for at least one or more of the common anxiety disorders. And those who had an anxiety disorder also reported significantly worse pain and health-related quality of life. What comes first, many of these researchers ask, the pain or the anxiety disorder? This is a tough question to answer. It's hard to see beyond their interaction to an original cause. On the surface, the presence of panic in endometriosis seems like a bit of a no-brainer, doesn't it? Who would not panic if her internal organs were under such a full-scale, systematic assault? Panic is an understandable, iatrogenically produced reaction to the amazing plethora of medical misdiagnosis many women undergo, and which exasperates us to no end. But when taking histories, I noticed something unexpected. If I understand the prevailing situation, the place of panic in endometriosis is far more complicated than initially meets the eye. I was surprised, for example, to pick up the finding that many women reported having panic attacks prior to the overt onset of endometrial symptoms. This can be written off as a pre-morbidity, but that oversimplifies the picture. Why, I asked myself, are 10 to 12-year-old girls having panic attacks like this? I wondered, is this an artifact of memory imposing suffering on the remembered past? Is it a specious finding? Could panic, I wondered, be part of a larger overall system, in statu nascendi, that is, in the act of forming, organizing itself prior to puberty? Is there such a thing as an occult endometriosis, the way there is, for example, occult bleeding? Recently, we have begun hearing about the secret endometriosis. This is endometriosis with no discernible symptoms. The idea of secret or occult endometriosis is based on observations of the differences between hard findings and an endometriosis sufferer's subjective reactions, such as pain. The relationship can go two ways. Hard findings, for example, an MRI or an ultrasound, and limited pain, or limited hard findings and lots of pain. I see a lot of the latter, but they're not hysterias. The problem is solved when we conceive of endometriosis as a complex, multifactorial system. In the lingo of medicine, this might be termed a syndrome, but for the purposes that we're here for today, it allows both pain and panic to be understood as component parts of a complex system, and not as pathologies in their own right. This leads us to study the organization of endometriosis itself, and not the raw phenomena. I'm now going to speak of a special kind of panic. The panic I see tends not to be the panic of the inexplicable, of panic without knowing why or when. Nor is it the claustrophobic panic of feeling trapped in a subway or an elevator. Nor is it the existential panic of a search for meaning in the void of a world demanding compulsory execution. After a while, and after I listened for a long time, I came to understand what it was. It was endometrial panic. Calling it anything else rationalizes key elements away and minimizes its distinctiveness. Again, we throw away the playbook. We can do better than the Procrustes bed of ill-conceived categories normed on other kinds of patients. If someone sat down to piece together a psychiatric and diagnostic system that intentionally threw women with endometriosis under the bus, it would be hard to do better than the DSM-5. Every woman with endometriosis assigns a different and therefore unique set of meanings to their symptoms. The clinician cannot make the mistake of assuming that since he or she recognizes the symptoms, that therefore they understand the meaning of the symptoms. Unless the clinician recognizes, understands, and works with the meanings unconsciously assigned by a particular woman, rather than the fact of those symptoms, the patient will inevitably feel estranged, alone, and isolated. And again, that was a lesson that took me years to be taught. And treated like an object rather than a truly dimensional individual. I think intuitive and gifted clinicians of all stripes naturally work in this manner. But we must do battle with the reductions forced on us by the quest for simple and replicable cures. Once you make this shift, potential remedies appear that are otherwise elusive. But to assess the individual system, two concepts are requisite. I'm going to call them displacement and symbolization. Bear with me. Without them, we are sunk. Through symbolization, an internal object acquires metaphor-like meaning. The representation of a thing becomes as important as the concreteness of the thing itself. I have previously, in previous years of this forum, described how desymbolization can function as a defense of last resort for the overwhelmed woman. It can be an adaptation to a cocoon-like state where there is finally respite from the pain and panic. Through displacement, one thing comes to stand or pinch hit for another. The mind substitutes either a new aim or a new object for goals felt in their original form to be dangerous or unacceptable. I cannot again emphasize strongly enough that both displacement and symbolization are unconscious and can only be reached through the interpretive act, not the goal of modifying conscious thoughts into better thoughts. Panic and pain can be thought of, then, as what I'm calling paired elements in the endometrial pain syndrome. Unlike other elements, they tend to move together to a jointly causal, ongoing progression. They share the work and fate of symbolization and displacement. That is to say, displacements and symbolizations act in accord with one another. It merits attention that this understanding is consistent with some of the most recent and interesting models in medicine. But these are topics that are far too long and involved to take up today. These and other less central processes become the cornerstones of the endometrial pain systems from a psychological perspective. Parts of the interactive system can be isolated in theory, but not in practice. Pain and panic participate in the syndrome in this way. Please notice that this in no way serves to deny that they both exist in some original form. They certainly do. The treating dilemma, though, is to untangle them so as to trace their evolution in the mind of the endometrial sufferer. I am here this morning, today, to testify that doing so can lead to relief of seemingly intractable pain and panic. I've been there and done that many times. One young woman, in dramatic fashion over time, came to be able to recognize that when she felt pelvic pain, it meant that she was panicking and in severe conflict over some matter. She had learned to consciously tie together threads of her endometrial pain syndrome. This provided powerful leverage over internal states leading toward her eventual recovery and living a pain-free life. Something else I have seen repeatedly we can now tackle, and that is the remarkable hypersensitivity to medicines present in many women with endometriosis. Where someone else will start on a dose of 20 milligrams of a medicine, the woman with endometriosis must start with 2, 3, 4 milligrams. Otherwise, the side effects become overwhelming. Failures on drug after drug after drug are quite common. And it is quite exasperating, again, to hear women describing how they were told to just get tough. Typically, drugs have targets. The targets are symptoms, and not organizations or systems. Is there some neuronal basis for this drug hypersensitivity? Perhaps. But there's another line of inquiry that might focus on how the elements in endometrial pain syndrome resist change. The dreadful side effects could then be understood as a syndrome's form of protest. Change must be slow in order for the endometrial pain syndrome to maintain some form of stability. In endometrial treatments, our expectations of time passing can be usefully reconceived so as to be native to this disorder and not another symptom or organization. I'm coming to the end now of my talk, and I will offer the denouement, my final suggestion. There are reasons why I think every woman embarking on treatment for endometriosis should automatically be provided, prior to surgery, with a brief psychological treatment for panic. That's right. I'm suggesting that all women prior to surgery be provided with a brief treatment for panic. This, to my mind, is research begging to get done. Such prototypes of brief treatment for panic disorder already exist in the psychological and medical field. I will take odds, if anybody wants to bet, that such a treatment will be cost-effective. The cost-effectiveness of certain psychological interventions in other medical disorders is a fact that was established over 20 years ago. Because of the self-regulating nature of the endometrial pain syndrome, I hypothesize that the best treatment for panic the brief treatment for panic, might well cut down on recovery time, on the need for pain relief, and on post-surgical anguish in general. Such a research trial would provide sorely needed information about how best to facilitate recovery from this disease. But it must be grant funded, and unfortunately, decades ago, I gave up that search, that part of my life, chasing grants, so I could spend more time with patients. And I've never regretted it or looked back. I want to thank you for hearing me out this morning.
Thank you, Dr. Wilson.